Thanks everybody for being here, and thanks to the organizers for putting together this great symposium. We're going to talk today about systems and some of the systems that patients with infection-associated chronic illnesses have to navigate as they're dealing with their illness. When someone gets sick with one of these chronic illnesses, it impacts every area of their life. Um, how you deal with your family and friends, your interactions with your workplace or school, trying to get health care and a proper diagnosis and treatment is usually the immediate priority for patients and their families. And unfortunately, if the illness persists, as it often does, uh, there's a need to go on disability or try and find disability and get support. We're going to talk about all of these areas with this panel today. And we've got a really nice panel assembled with perspectives on each of these areas. Dr. Paul Guyre is a caregiver for his wife and a professor and researcher here at Dartmouth, a professor of microbiology. Jehan Keziere is a patient who got sick when they were quite young, and can share their experience dealing with the illness in an early part of their life. You've already heard from Lisa McCorkell, who's been a tremendously effective advocate, along with being a long COVID patient, and has really helped transform our understanding of the illness in the public sphere. And Dr. Howard Selinger. Howard, can you hear us?
I hear you fine. Can you hear me?
Yes, terrific. Is a professor of medicine at Quinnipiac Medical School, and has a really unique position because his endowment and his endowed chair at the school comes with a mandate to educate students about ME/CFS, long COVID, and infection-associated chronic illnesses. So Dr. Selinger will share some of his experiences in bringing greater awareness of these diseases to physicians in training. I'll give you a little bit of background about myself. I'm a scientist, a researcher, and most importantly, a caregiver for my wife, who came down with ME/CFS almost 20 years ago. It happened, like many cases, after what you would normally think of as a 24-hour flu. She kept on getting sicker and sicker, and over a course of several months, she was bedbound. And that lasted 7 years. Different degrees of severity, but we saw God knows how many doctors, dealt with many of the stigma, the dismissal that you've heard about. Thankfully, she got better, which I think is probably not the norm. Her degree of improvement, she was able to go back to work. We had our son, who's now 12. 5 years ago, she had a relapse, and again was bedbound for parts of that time, had to go back on disability. Thankfully, the last few months, she's been improving. One of the things I learned the most about this experience is just how fragile the bonds are that connect us with some of the outside world and the systems we deal with. Like, in the pre-days, I wouldn't have thought that a healthy person could just be so sick and unable to function, and none of this shows up on the standard test that they do in the doctor's office. And I think seeing how people who have to deal with these diseases get through the day and where they find sustenance and support is always inspiring to me. And so hopefully in this panel, if you're a healthcare provider or a medical professional, you'll gain a better understanding of the experience of patients and their families. And if you're a patient or dealing with these illnesses yourself, you'll have a sense of community from people who've walked in the same steps as you, and may learn some things about how they've dealt with it. So I'm going to allow each of the panelists to tell you a little bit about themselves and their story and what brought them to this place. Paul, maybe you could start.
Yeah, so yes, I've been a Dartmouth professor since before most of you were born. I was co-founder of Medirax, the company that made the anti-cancer antibodies, which have saved hundreds of thousands of life years for cancer patients. Despite my great resources, financial security, and connections with leaders in the medical community, I was unable to find help for my wife. I'll tell you more about that later.
Jehan?
I'm Jehan. I am currently 24 and I was diagnosed with ME/CFS at 17. Something important to my story is that before I got sick, I was struggling with my mental health. When I started feeling sick, my brain was doing the best it had in years. I loved the classes I was in. I was feeling joy again. I was sleeping a solid 8 hours a night. I was managing my anxiety and I was doing well. But suddenly my body wasn't doing so hot. The first thing I noticed was that I kept falling asleep in class, despite the fact that I cared about the subjects. Even when I wasn't sleeping well, that had never happened to me. I was sleeping a good amount, but it was like it didn't actually do anything. Everything seemed to take up so much more effort than it should, walking upstairs, carrying a bag, even just talking to people. My short-term memory started to get worse as well, and I felt like I was thinking through molasses. There was something wrong with my body, and I knew it wasn't in my head, because I knew my head pretty well. A year later, I was diagnosed, but by that point, I couldn't make it through a full day of school, and I was using mobility aids to get around the building. I dropped out without graduating, and since then, I've been focused on my health and regaining what function I can. I can't work, I'm not in school, I am a full-time sick person.
Thanks, Jehan. Lisa?
As you heard before, I'm Lisa McCorkell, and I'll give a little bit of background as to my illness. So I got COVID in March of 2020, had a mild infection, was unable to access a test because those were limited. And the following few weeks kept getting worse and worse. I was unable to walk a block without severe heart palpitations and shortness of breath, when previously I had been a long-distance runner. Healthcare providers dismissed my concerns, said I was deconditioned from the virus, and that it was, largely, something I needed to work through with, maybe some antidepressants. That is when I joined the Body Politic COVID-19 support group and found other people going through the similar experiences I did. I continued to experience symptoms for a few months, and then largely recovered, which now I recognize was a period of remission. I went to an exercise class and pushed myself too much beyond a limit I didn't know that I had, and then was bedbound for a week following, and have still been trying to make up the difference since then, and that was over 3 years ago. I did have two big jumps in improvement. The first was after the first dose of the COVID vaccine, and the second was last year. I started taking nattokinase and serrapeptase after I saw that I was lucky enough to be tested for microclots, and just started taking those after that test. Now I have very mild long COVID at this point, I would say, with my main symptoms being still some post-exertional malaise that's largely managed by pacing. I have premenstrual dysphoric disorder, and I always forget the last one, and it's literally brain fog, which is, ironic. And POTS, postural orthostatic tachycardia syndrome.
Thanks, Lisa. Dr. Selinger?
Sure. Unlike everyone here, I don't have a personal experience with long COVID or with ME/CFS, but as chair of family medicine at the Netter School of Medicine, which has just celebrated our 10th anniversary, and I also teach in a community-based family medicine residency and continue to see patients. As relates to this symposium, my goal is to validate and legitimize patients who present to me with symptoms suggestive of long COVID and ME/CFS. And also, I came to this unfamiliar with these conditions until a woman approaching her 8th decade wanted to make an endowment to endow my chair on the condition that we would develop an action plan to incorporate educational educational mandates for our first, second, and third year medical students with an opportunity for a fourth year elective in the School of Medicine. And that was the ask, and that is what we have done at the School of Medicine. And that there's nothing more important as concerns these types of illnesses than validating and legitimizing in the young medical minds so that they come to accept it and don't develop and strengthen biases as they enter their clinical career.
Thank you, Dr. Selinger. And we're going to start with navigating the healthcare system, which is, when people get sick, usually their immediate priority. How do they find out what's wrong with them? How do they get a treatment? Jehan, so you developed your illness at a very young age, 17, I believe. I think there's maybe a misconception out there that long COVID hasn't been affecting young people. In fact, estimates from the Recover study suggest there's at least 1.4 million pediatric patients with long COVID in the U.S. Other studies found at least 500,000 pediatric patients with ME/CFS in the U.S. So there's a lot of young people suffering. Jehan, so what was it like for you to develop this chronic illness at such a young age, and how did you find your path to a diagnosis?
I think after it was about a month and a half of experiencing symptoms, I started getting concerned that it wasn't going anywhere. And I did what you're not supposed to do, which is Google it. I'd read a post online that mentioned chronic fatigue, and I figured if it doesn't go away, it's chronic. So I Googled the term and found a test that adds symptoms and lists symptoms and adds them up at the end. And if you score higher than 10, you might want to see a doctor. And I got 23. It was kind of, the more I learned about it, it was a bit of an existentially terrifying thing to realize that I wasn't getting better and I might never get better. I remember thinking, if I could be stuck like this, I'm going to have to accept that now at 17 rather than have that realization later. It didn't really make it any less soul crushing, but it was nice to have the hammer and do it myself rather than let time do it. I think accepting that I might not get better gave me this kind of stubborn determination to make my life as good as it could possibly be, sort of out of spite for that fact. And that fueled a lot of my self-advocacy early on. A lot of the doctors I met while pursuing diagnosis and since then had never heard of ME/CFS and didn't know how to recognize my symptoms at first. I'm really lucky in that I got a diagnosis in about a year. I had some practice advocating for myself in medical context as a transgender person. So I was prepared to do that, but I want to point out that a lot of people, especially people who are diagnosed younger than I was, will not have that experience, and they will not. Advocacy is a skill, especially self-advocacy, and it's not something that we're taught in schools.
Thank you for that, Jehan, sharing your story. Did you feel like physicians were less willing to take you seriously because of your age?
Absolutely. I think that especially somebody who never graduated high school, there's this degree of, oh, you looked it up online, so you think that you know something, when in reality, a lot of research before this point had been patient-led. I do remember an experience of my mother, who is now very supportive and has done a lot of research, coming in with this full binder of information on ME/CFS from patient-led organizations, ready to like talk to a specialist about what my symptoms were. And the specialist refused to read any of it and then recommended that I should exercise more, which was frustrating. Yeah, I've seen quite.
Yeah, we've certainly dealt with for sure infuriating reactions from doctors. Yeah, what you said reminds me of the issue of privilege, and I think my wife and I, despite the misfortune of her getting sick, have been privileged in many ways. One of the things I've observed in our interactions with doctors is my wife's a scientist as well. Is once they find out that we're scientists, whether it's particular language we use or just asking about our backgrounds, they definitely very often have a different response. I can't say how many times we've come in with this binder full of papers and medical records, and the eyes glaze over. But once they see you have a scientific background, they might treat you differently, which is not the way it should be. Patients know their condition and are able to learn about the illness, and in many cases actually know more about it than physicians. I'm curious, Paul, we share, I think, some common background as both scientists, researchers, and caregivers. How has the response been among your colleagues as you've turned your research to chronic illnesses, as you've tried to find care for your wife? Did you encounter a great degree of skepticism?
So my wife, formerly a mountain hiker and paddler, was told for 7 years that there was no identifiable cause for her debilitating fatigue. Since all tests were negative, she was said to have ME/CFS. We live in Lyme, and as a professor of microbiology and immunology at Dartmouth, I'm fortunate to have supportive colleagues who never doubted me. But I know that others have encountered disbelief and bad faith responses to their disclosure of chronic illness. As you will hear, support for science can be game-changing. I can talk about that now, or we can do it later.
I'd love to hear your perspective on that, Paul, especially what you think would help bring more researchers and medical professionals into this field.
I think just knowing that an understanding of the condition can really lead to improvement. And like you said, it's often post-viral or post-infectious. And my wife's case, it was babesiosis. And, connecting finally with Dr. Stephen Bach in Rhinebeck, New York, he was knowledgeable enough about lab tests that he noted that while she had a low antibody titer to the tick-borne agent Babesia, and most physicians would ignore that because it was, very low titer, but her total antibody levels were also so low that he suggested we treat her for Babesia, and in 2 days she was cured from that disease.
That's great that she was able to find the right treatment, and unfortunate it took so long to get there. Dr. Selinger, I'd like to get your perspective on this issue, especially as a physician. Do you face stigma among your colleagues, and how do you think we can bring more medical professionals into this field?
Well, I don't face stigma because I'm at a relatively young medical school, and we've had the pandemic, which has driven home the message that you can have a disabling post-viral syndrome. And no one can argue with the population statistics around long COVID and its similarities to ME/CFS, especially when it's supported and comparisons are made at the highest level of the National Institutes of Health. Again, I'll reiterate, though, my goal, and we can talk about that when we get into education, is to impress upon the students that there is now solid medical, scientific, and epidemiologic evidence to both validate and legitimize the presence of these post-viral syndromes and the disabilities that derive from them. I have yet to encounter any pushback from the standpoint of bias, but rather from the standpoint of other people having their own strong feelings about what topics of medicine need to be introduced into the curriculum. But pushback has not been an issue, again, in the educational environment where I work.
That's good to hear. Yeah, I know our experience with my wife, she was often seen as an outlier, one of these, very unusual patients that has so many different symptoms, and the doctors always ask, well, what's the main one? And I always struggled. I felt it was a struggle to convey at times the depth of her disability. I really liked Dr. Bateman's formulation of just the amount of hours you can be on your feet, because at times I know for my wife it was shockingly low, and I try to get that across, like she's really in bad shape, and there's this medical saying, when you hear hoofbeats, think horses, not zebras. And I'm struck by some of the discussion and also how common these illnesses are. So I'd like to get your perspective on that, Dr. Selinger, about, physicians being able to recognize patterns, and how do you make a diagnosis when you see a patient come in? What's your kind of checklist, and how long does it take you to reach that diagnosis?
Well, I wasn't able to participate in the earlier parts of this symposium, but hopefully it's been pointed out that there are specific criteria that support a diagnosis of a post-viral syndrome. That can be 6 months of duration, the presence of multiple experiences of post-exertional malaise, cognitive impairment, and this is the history taking I go through with my patients, the presence of unrefreshing sleep, and often orthostatic intolerance. And I explain these terms to patients. The first visit is simply going to be the gathering of history. And you begin to explore what studies have already been done, almost all of which will be normal. How many doctors have they seen? And as you hopefully were shared that information, it could be up to half a dozen. How long has it taken over these many months for someone to present the possibility of a post-viral syndrome and ask patients to think back? So it's all about the history. You're not going to find answers involving a physical exam, though we'll get to some specific tests. I guess now's the best time. I have every patient do a NASA lean test, which, again, I don't know if that was covered. You simply lean against the wall, semi-upright, and you record a person's pulse and blood pressure over about 10 minutes, and you should see a significant drop in pressure, a significant rise in pulse. This represents autonomic dysfunction, orthostatic intolerance, and it is one piece of objective data, along with the rest being historical information, that you can begin to validate for the patient that they meet accepted criteria in the literature for this type of disease state. And that's how I pursue this. Now, there are tests that you review if they've been done, that you check on if they have not, but it's really about the history.
Thanks, Dr. Selinger. And then that, I think, is very consistent with what Dr. Bateman was saying in her experience. And I know from my experience with my wife, there's a striking difference in seeing physicians who are experienced in treating these types of illnesses versus others. Paul, I think you wanted to add something.
Yeah. It, it seems that there's too few doctors that understand the similarities and differences between these various infection-associated chronic illnesses. And my question for Dr. Selinger is, have any other medical schools contacted you to incorporate this into their curriculum?
I was contacted by a school in the United Kingdom probably a year ago. They were interested, and I forwarded to them, our curricular elements in the first 3 years of the 4-year medical school curriculum. I have not yet been contacted, nor do I know of any domestic United States medical school, though that doesn't mean it doesn't exist. But I have not heard through the American Association of Medical Colleges or other organizations that there has been a concerted effort to deploy this at the earliest stages of the curriculum.
Well, what do you think it would take to get there and make that spread?
To be perfectly honest, in my case, I came at this as a neophyte, and it took a patient approaching the medical school and de novo saying, I would like to make a 7-figure donation on the condition that you develop actionable steps to introduce to your medical student population the condition of ME/CFS. This is pre-pandemic. So I really think it takes a champion. It may take someone who wants to bring sizable funds to the school. I'm sure none of the schools would turn that down. And then it takes an advocate and a champion who's going to politely beat the table in curriculum committee on oversight meetings. We all know there's too much medical information to share in the first 2 undergraduate years, and then everyone's off to clinical rotations. And so there's competition for curricular time, and you have to be very creative and insistent and hope that you've got advocates who will listen to you, recognize public health importance, and make decisions that please some and disappoint others. It is a political arena, as are so many things in life.
And talking about advocacy and politics, Lisa, you've been involved in raising public awareness of long COVID and spearheading patient research into the disease from nearly the beginning, and have had some very influential articles, including the Nature Reviews article that was mentioned earlier. How have you seen, from your perspective, physician care evolve over the course of the pandemic?
Yeah, so I think at the beginning, especially like 2020 into 2021, many people with long COVID, our first initial experiences with healthcare providers was dismissal. At the best, maybe just like, you just need to rest more, which was good, that was good advice, but didn't necessarily address any treatments, or they didn't necessarily know about ME/CFS, or that there could be any long-term sequelae from a SARS-CoV-2 infection. So over the last 3.5 years, there's been a lot of progress made. I'd say like the bigger problem patients are facing now is less dismissal, more we just don't know anything about long COVID. We know it happens, but we don't know anything. There's nothing we can do. It's good to like validate what someone's going through. Obviously, I talked about that earlier, and there are still clinicians out there who are dismissing these patients, but a step further than that is really being able to look at what evidence is out there for treatment and being able to refer to providers who are knowledgeable on these topics. And I think even, a lot of times a patient will go into a doctor's office, they may be experiencing these symptoms, they might not connect it to their COVID infection. They might not be connecting it to what incited their illness. And so that's also, I'd encourage healthcare providers to think about that, it's not necessarily a patient's going to come and say, I think I have long COVID. Unfortunately, we don't have enough public awareness broadly about long COVID. And so when you're asking questions about history, when do you think you had COVID recently? When was that? And knowing that many of these symptoms, it's not a direct line from COVID infection to these long-term sequelae. Neurological symptoms often onset months after a COVID infection. And so being kind of aware of that, and when you're taking your history, being knowledgeable of or asking questions about potential infections, including COVID, including Lyme, other things that might open up the door to see if this is an infection-associated chronic condition. But yeah, so I'd say, I think providers at least are aware more that it's an issue, but where we need to make a lot more progress is in the curriculum, so that when people are in medical school, they're getting this education. When something is affecting 6% of the American population, at least, it boggles my mind that it's not a top priority of medical schools to teach providers about this. And even in pre-med, in pre-health, like, we need to get this more socialized because these conditions have been neglected and dismissed for so long. We have a lot of work to do to catch up. And really, the providers that are doing well on this and are staying up to date, that takes so much effort and work to stay up to date on the research. We have to make it easier for providers to learn about this. And, a lot of times patients will take information. A lot of patients took the Nature review, and that changed previously, dismissive providers' minds when they saw there's a Nature article that covered hundreds of studies about biomedical findings. Like, that type of stuff can change minds, but often patients don't have the resources or ability to look up this and do their own research. So we have to find a way to do better healthcare provider education, both continuing medical education, but also really starting from medical students.
Yeah, there's a structural aspect of this that in the earlier discussion as well. I know for my wife, some of her most effective and best providers were also the ones, they're running like hours late because they spend somehow an hour with each patient. I don't know how they do it, but it takes a lot. There's this aspect of the disease that I think there's it's sort of you don't look that sick, and there's this invisibility that comes with it. And in my experience, the times when you're the most desperate are the times that you're the least visible, because you can't go out and doctors don't see you when you're at your worst because you're at home lying in bed. Jehan, for you, you became sick when you were in school, and how was that experience for you with your classmates, your peers, and your social circle then? And were people around you able to understand what you were going through?
Not many of them. In a word, it was frustrating, really frustrating. There's this idea that people that young can't possibly get sick forever. They'll just bounce back in a month. And when you don't, no one around you really knows what to do with you. I was a senior. I'd missed quite a bit of school already due to previous mental health struggles. So I was just trying to graduate, like get by with the minimum requirements to graduate. The problem was that I could no longer do 4 classes a day. My health was getting worse from pushing myself constantly. I didn't know at the time what post-exertional malaise was. No one was able to recognize it in me. So I wasn't budgeting my energy the way that I know how to do now, but I knew I couldn't keep going like that. At a certain point, I stopped going to classes altogether and I sat outside my guidance counselor's office until he met with me about credit requirements. I'd make eye contact with him whenever he opened the door for something because it felt like unless I made myself as visible as I could, they'd just ignore me. There was no precedent for that kind of illness in the system. There was no flexibility about how long I could be in school per day. I felt like my only options were to either burn myself out, trying to function just like any other student, or give up and not graduate that year. It didn't feel worth it to spend another year fielding the same questions from teachers and peers about why I wasn't in class. It was a really isolating experience because no one really knew how to act around me anymore. Because what do you say when your classmate suddenly comes in with a walker, other than, hey, do they let you use the elevator? Can I also use the elevator? It wasn't just my peers. I once had a substitute teacher for a class that I was the teacher's assistant for offer me an orange because vitamins are good for you. I didn't really know how to tell her that it would not work. My parents are now a fantastic support system, but at the time, for about a year, they didn't quite believe what I was trying to tell them about how my body was falling apart. So I was on my own dealing with the school system. It was a lonely and frustrating experience. I found out later that there had been other students in past years that had ME/CFS at that same school, and it baffles me that the school system had not learned from their struggles. And I hope that they learned from mine, at least somewhat.
Sharing that, Jehan. It's very isolating, alienating in some ways experience. I know for us, we had this feeling that people around us, similar age, is they can't relate, and it's like you're living in a different world. And it takes a lot of support around you to make it through. Paul, in your workplace, as you were, because being a caregiver, it takes a lot of time and effort and energy. How were your colleagues in understanding and supporting you? I mean, did they realize what was going on? And was the institution supportive?
So my colleagues were all very supportive. As far as the institution being supportive, I don't think there was a good place for her to go for that. But another story about her demonstrates that proper research funding can lead to cures. A month after she was successfully treated for babesiosis, she was diagnosed with metastatic pancreatic cancer. Thankfully, science saved her again. Her tumor was positive for mutation in the tumor marker BRCA2. So thanks to the outstanding oncologist, Dr. Catherine Hordekin, who said I'm allowed to mention her name, Dr. Hordekin entered her in a new clinical trial where she was treated with the drug Lynparza plus an immune-boosting monoclonal antibody. Today, her cancer is in remission. We hope that funding for ME/CFS research will be greatly increased so that this condition can also be helped.
Thanks for sharing that, Paul, and we certainly hope for the best for your wife. With research funding, I'll also say I'm an industry scientist. I work for a biotech company, and it's tremendously frustrating to me the lack of industry involvement here, especially when there's such a huge unmet need. And some of it, I think there's practical reasons, the lack of molecular biomarkers, difficulty in running trials, but part of it's just a herd mentality. I think, people see one treatment succeed, and then you have tens or hundreds of copycats, and it really takes you see it in the field. I think a lot of the people and the researchers involved, they have a personal involvement, and it shouldn't take that, because just biologically there's this huge gap between what's done in the clinic and what you can do in the lab, and there's a ton of findings of abnormalities in these patients, just not molecularly what are usually tested for in the clinic. But hopefully we'll get there someday. Lisa, talking about the workplace, how do you think workplaces or schools can provide accommodations for people with these sorts of illnesses, and have you seen that evolve over time?
I wouldn't say it's evolved. I think as patients, we have an understanding of what we need to participate. And it's important to recognize that long COVID is a recognized disability under the ADA. And so patients have the right to accommodations. Unfortunately, often these are not enforced. And so it can be difficult to get the accommodations. One of the barriers is getting an adequate healthcare provider's note, which is needed. But then often, some companies are just unwilling to necessarily accommodate. But it is critical to try. Some of the important accommodations that can help include telework. Flexible schedules can be really important to make sure people can pace. So, often people, not often, but some people are able to work full-time or part-time if they're able to have breaks throughout the day, but that's so different than how work is generally structured in our society. And so making those types of accommodations, if you have a job that's normally standing, being able to move to a role where you can sit. Those are some of the accommodations that have helped. And I think, so about a year ago, I think in August, Brookings put out a paper that estimated about 4 million Americans were out of work due to long COVID. This was a pretty conservative estimate. We know now, obviously, it's grown much more as the number of people with long COVID has grown. In our paper, we found that 2/3 of people with long COVID had their work impacted, whether reducing their hours or had to stop working completely. And that's not even the full picture. A lot of times, if people are able to work part-time or full-time, that is all they can do. So they are working because that is how you're able to pay your bills. And when you come home or when you stop working, you have to rest. You can't do other chores. You can't do other errands. You can't socialize. And so I think even the numbers don't really show how much of a crisis this is, because if you stop working, then you may be reliant on government benefits, which are very difficult to get on. And so there's just no real solution for a lot of people. So anyway, accommodations are a critical tool. Unfortunately, without the enforcement from the federal government of making sure that people are approved for these accommodations, it can be a moot point, but it's important to try to advocate for yourself in a workplace environment and get the accommodations you need. And I also think there's just so many out there. And the government does have some good websites on this. Department of Labor has a list of suggested accommodations that you can look through and maybe see if that would be a helpful accommodation for you to ask for. But really, being creative and trying to make it so that work is not the only thing you're doing, like asking for enough accommodation so that you can have a life outside of work and that you're able to take care of what you need to take care of if that's possible. It's not possible for some more severe folks, but if it's possible.
Thanks, Lisa. And that brings up the issue of if a patient is no longer able to work, and then they have to apply for disability benefits. Dr. Selinger, could you comment on, you mentioned the tilt table test. Are there, do you use that or other objective tests to advocate for patients who are applying for disability, or what is your role there if a patient of yours
Sure.
is applying for disability?
Sure. Well, my role is one, as I said, is to educate students and residents. But now, as we're getting into the direct patient care, my role is to let the patients know that the Social Security Administration will recognize a cardiopulmonary exercise test, which is the CPET term used, which measures the oxygenation peak, the ability of a person to stay oxygenated during exertion and not become what we call anaerobic. Or, I used to run long distance, and you want to run at your best aerobic pace. You don't ever want to become subject to an oxygen deficit. This test is commonly a 2-day test, but can also be done in 1 day in a more invasive way that involves the placement of catheters. This has been shown to allow people to receive Social Security disability approval by demonstrating that, unlike the control population, especially on the 2-day test, they are unable to reproduce the oxygen levels achieved with exertion and the duration of exercise on day 2 that they were able to demonstrate on day 1. These are not done everywhere, and I've had to locate the major university-based facilities that offer these tests, usually within the departments of pulmonary. And they can also materially impact a person's quality of life for quite some time, diminish their baseline level of functioning because of the crash, which you are all familiar with, that they experience after completing this on the 2nd day. But it is one of the few objective, numerically recorded procedures that are recognized by the Social Security Administration. I'm not going to go into the details of it, but they are not able to perform at the level of the controls. They produce abnormal results, and much of it relates to the inability to oxygenate, which there's debate about whether that represents dysfunction of the energy cells of the body called the mitochondria, or whether that represents dysfunction in the transportation of oxygen to the muscle cells from the lungs, where the oxygen is restored as the blood circulates.
Thanks, Dr. Selinger. I know in my own experience, after my wife had been sick the first time for a couple of years, we did apply for SSDI. And again, we're fortunate that we had some very experienced physicians who were able to provide documentation of abnormal test results, including autonomic nervous system dysfunction. And that was a great help in getting her case approved. Also, if my employer hadn't been flexible, the process takes a tremendous amount of time. I think it would have been quite difficult. Lisa, do you have anything to add about guidance for long COVID or ME/CFS patients who are trying to navigate the disability process?
Yes, there's a few guides out there. I think one of my favorites is this blog, howtogeton.wordpress.com. It's overall just an amazing blog, but there's specific tips on how to apply for disability for people with these types of conditions. So I'd recommend going there. Social Security Administration just in the last few months put out guidance for healthcare professionals for how to properly document disability for long COVID. And so I would recommend that, obviously, the healthcare professionals, but also for patients to review that so that you can take that to your healthcare provider. You can make sure that they are documenting what is needed to be documented. In addition to the 2-day CPET, I know people with ME/CFS and long COVID have found some success with documentation of neuropsych evaluations. That can be also really draining, though. Like, the type of evidence they need is usually takes it like a day long. which can be exhausting for patients, but does get you potentially what you need. But unfortunately, the system is just broken. The vast majority, almost 80% of people who apply for SSDI are rejected on their first round. Then you go through the appeals process, get a hearing. Ultimately, only about a third of people who apply for SSDI end up being approved. It takes a lot of energy. It takes a lot of time. It is not a good process. And once you get on, it's, at least some funding, but it's not a significant amount and you have many limitations. So there's a lot that needs to be improved on there on the policy front. But I think it's important to have, I guess, that expectation going into it that, try to document as much as possible. But you may get rejected. Trying to get some legal assistance if possible to help you build your case is really crucial. And then another thing to do, especially if you haven't heard back, if it's been a long time, the wait lists for these applications are so long. You can contact your congressional representative and they can check in and see how your case is going. So that's another option for patients. Yeah, unfortunately, the system is just not set up for this. But I'm glad that the SSA recently put out this guidance, and I'm hopeful that that'll lead to more approvals. Because right now people are just working when they can't actually work and pushing themselves and making themselves worse.
Thanks, Lisa. When we're talking about systems, of course, a chronic illness like this affects those closest to us and affects our relationship with them. And Jehan, you talked about how isolating this can be, and how some of your peers and friends at school responded. What gave you sustenance, and what has helped you get through, and where have you found community?
It's been a lot of online. I do not have the energy to meet people face to face very often anymore. When I do, I need to work up to it. It's like that is my energy envelope for the next week. But almost every night I am able to connect with friends that I've met online and play video games. And it's something that seems very small, and to them probably is, because they have this whole world open to them where they have careers and relationships and lives. And for me, that is my whole day. It definitely keeps me going. And I think that I have found and made meaning in that sense of community. Something that I found pretty early on was that in a lot of online spaces, even unrelated to disability in general, you will find other people with chronic illnesses. They could be from another country, they could be from across the world, but you connect to them through similar experiences in a way that I could be in a room full of people my age and not a single one of them understands me. And meeting people online who I would never be able to meet in person because we're all over the globe. And almost every one of us has a similar experience about feeling isolated, feeling alone, struggling with the medical system, trying to get help, feeling disbelieved. It's a common experience, which is frustrating, but also bolstering when you know that there are other people out there that understand that and that you're not alone in it.
Yeah, thank you for sharing that, Jehan. Sometimes I feel there's a kind of shorthand with families who have dealt with this. It's, you just start saying something. It's like, oh, you know what I mean. And there's a tremendous sense of loss, and I think it's still something I know my wife deals with to this day, because it's this idea of the life you could have had, should have had, that's kind of hovering there, and at some point this becomes the life you have and are living with. So if anybody wants to comment on how they've come to terms with that, or dealt with that loss, or addressed that grief that comes with having a chronic illness like this.
I can go for it if you don't have anything. Sure. It's I think it's something that, in order to advocate for yourself, especially that first year when I was trying to get a diagnosis and I didn't feel like there was any adult in my life that believed me. I was 17. I knew there was something wrong with my body, but I didn't have the words for it. I think that I put that grief in a box and I turned it into rage. I turned it into frustration. I turned it into like, okay, what can we do now? Who can we talk to? Who can I email about this? And it's something that the box only opens when I am sitting alone in my house at the middle of the night and I'm thinking about the fact that I could have been in a college dorm right now, that I could have still been in contact with my best friend. And I think that it's something that you take one thing out of the box at a time. You have to unpack it slowly, and it's never quite done because it keeps getting added to every time you remember something you could have had but don't. And I think that it's possible to be happy while still being grieving for a life you could have had. It's not an easy thing to do, but it is possible.
That was very well said, Jehan. Dr. Selinger, are there resources you try and suggest or provide to your patients to help them deal with this, loss that they're facing?
Not just my patients, but my patients and their partners, their families and loved ones. The resources really are the state societies with which I have contact. That would be ME Action. That would be the Bateman Center. Not so much that they're going to fly out to Utah, but that the Bateman Center can direct them towards a number of online resources and support groups. That's who I use, and I would say half the patients are extremely well acquainted with the availability, given the access of the internet these days. But they always do appreciate the opportunity to learn more, and again, to validate for them what they are experiencing, so they don't question it, they don't feel guilty about seeking support.
Yeah, that's huge. I mean, it's especially given the stigma, and I think the tendency to psychologize the disease among some medical providers. There's I feel like from the patient's perspective, almost you don't want to seem depressed because it's the easy answer for your doctor, but who wouldn't be? It's the natural human reaction in that situation. Paul, as a caregiver, are there things that have helped you, sort of carry the burden and get through the day-to-day that have helped you and your wife?
Well, again, as I said, I'm just very lucky to have so many supportive colleagues. And since I run a research lab, we've been able to try to identify biomarkers that could be useful to track whether any treatment is going to help. And also, I'm number 6 in a family of 14 children, so I have many siblings who have been so supportive that I feel very fortunate that I really have help with everything that I need to do to try to keep my wife as well as possible.
Thank you for that, Paul. We have some questions from the audience that we're going to take now. Here's one. So if a person is housebound, how should they see a doctor while avoiding a crash? Excellent question. I would say from my perspective, it just has caused a crash many times, and we've just had to plan around it, knowing, this appointment that's taken 3 months to get. We really need to see a doctor, and it's going to be a week after that's going to be pretty bad. I think telehealth has helped, certainly. I don't know if Dr. Selinger or Paul or anybody else has anything to comment on their experience. Paul?
Yeah, I can just say that COVID has made it so much easier because we all know Zoom now. So telemedicine is so much easier than it ever was before. So we've been able to have, appointments and interactions with several physicians far away that we never would have been able to get help from previously.
Lisa?
Yeah.
Just looking to the future of medicine, I am very hopeful and hope we can all push for the acceptance of more home visits so that people don't need to do that type of, have that type of exertion. But then also, there's some clinics that have, once you arrive, so you do have to get there, which can be a lot of effort. But once you arrive, having a resting room with low lights, having the clinic just generally have low lighting, low sound, because for more severe patients, that can be very triggering. And being in the clinic, just having that being an accommodating place is so crucial, and something that often is the exact opposite of what happens. Like, it's not just the energy it takes to get to a doctor's office, but doctor's offices just have so much sensory stuff going on, and for someone who has sensory sensitivities where that can trigger a crash, that can be very difficult. So I think I'm hopeful in the future that that type of environment can be adopted more in clinics, so that where you're seeking healthcare, it's not also causing your health to be worse.
Yeah, and I know the subject of physical therapy came up earlier, and needing physical therapists who are experienced in these conditions, because it's very, very different. And we've had some success with the virtual physical therapy with experienced folks, because it sometimes I can only do 5 or 10 minutes, and it really doesn't make sense to do an hour round trip for that. That's an exhausting trip, and then pile that on. So hopefully there'll be more options available in the future. Someone here has a comment, but I think it's interesting. This is from someone who teaches first and second years here at Geisel, asking if infection-associated chronic conditions and ME/CFS could be, for instance, the step 1 question of the medical boards. I'm not sure exactly what that involves, but maybe Dr. Selinger, can you comment on, I guess this goes towards integrating into the medical curriculum, but how realistic do you think that is, or how far are we from something like that?
I don't think we're too far away. I think, again, the pandemic and the presence of long COVID has driven the message to the powers that be that sit on the AAMC and create the medical boards. There's step 1, step 2, and step 3. Step 1 is usually taken at the end of the second year. And I don't sit on those boards, but one would hope that the impact on the population would drive constant revision to keep those test questions relevant. They are pass fail now. They are not scored numerically, and that's a good thing. and they are required to progress to the next level of training, which is graduate medical education and residency training. So, yeah, I think it would be very important to try to advocate to those organizations to get their feedback and begin to have some sort of dialogue. Certainly, the NIH is involved in not in that aspect of testing, but in creating videos and training sessions at the medical school level.
Thanks for that, Dr. Selinger. We have a question here about, are there peer-reviewed trials looking at long COVID treatments, randomized studies? Lisa, maybe you're aware of the current state of the art?
Yeah, there's some. So Patient-Led Research Collaborative is funding one through CSF that's on a monoclonal antibody. So that is enrolling patients now. There's a few through Recover that Dr. Bateman spoke of earlier. There's a few on repurposed drugs that I'm excited about. I'd say there's I'm trying to remember, which I'm going to blank on how many there are, but there's a handful. There's still, unfortunately, a lot of trials that are on rehabilitation techniques or exercise and really not learning from what we know in other conditions that are similar. And so what we're trying to push for is more trials on repurposed drugs, even if it's, very small scale at first, just so we can show, if there is any efficacy at all. Yeah, Paxlovid is being trialed, a few different trials on Paxlovid. There's a company in Houston is doing a trial on stem cells. So there's a few out there. I expect, in the next few months, we'll have some of these results come in. And largely what's missing from this is we need more funding. All of these clinical trials have kind of been scrappy in how they've been funded. We need federal investment for that largely, but also we need pharma to get involved, and we just need more industry engagement there.
Thanks, Lisa. And one final question, just a tough one. Is it better to go to a clinic than a primary care provider, since the PCP doesn't have the time or the necessary time or the experience? I assume that means like a long COVID or specialty clinic, which there are not that many of. I guess obviously, hopefully your PCP would have the time necessary. But Dr. Selinger, do you have comments on that?
It depends on the individual clinician. More than 3/4 of clinicians in this country are now employed, and it's sad to say that they are under the scrutiny of the health systems that pay a lot of attention to what we call resource value units, which determine the revenue generated by those clinicians. So they're under pressure to deliver volume, and that interferes with the ability to gather quality and take the time that's necessary for adequate history taking. By the same token, if you have centers like the Bateman Center, then I think you are certainly advised to seek those out and to see if you can engage with them, be it remotely or in person. But there are unfortunate economic pressures at play that limit primary care physicians' ability both to commit the time and, unfortunately, still to validate and legitimize what their patients are telling them. So it's a challenge, and I'll leave it at that.
Yeah, there's a lot of inequity in the access people have to medical care. I know for us, we did a lot of doctor shopping, and if someone didn't have the time, we saw their doctors, but not everybody is able to do that. Well, I'd really like to thank the panel for sharing their stories and their time here. It never fails to inspire me, the things that people make it through. So thank you all.
Happy to be here.